The following portion is a pre-recorded webinar presented by Dr. Ross Leighton. Dr. Leighton is a professor of surgery at Dalhousie University in Halifax, Nova Scotia, who has specialized his practice in orthopedic trauma through fellowships both in Canada and in the US. Dr. Leighton is a past president of the Canadian Orthopedic Association and of the Orthopedic Trauma Association, or OTA. He is currently the president of the Canadian Orthopedic Trauma Society, which is active in numerous clinical trials, including the one we will be discussing shortly.
I can assure you this information I'm going to give you is not the old stuff that you've listened to about compartment syndromes in the past. It's new, exciting information that I think will potentially, as the study unfolds over the next few months, may change the way we do practice and how we handle acute compartment syndromes going forward. This is the diagnostic impasse, of course. Are the clinical signs enough? So we get prophylactic fasciitis. We don't do too many of those. At the same time, we don't want to miss any acute compartment syndromes, and we want to make sure we get all of those, as we'd rather have fewer of those and more of the prophylactic going forward. But can we find a nice impasse that will reduce the prophylactic fasciitis and at the same time completely avoid missing any acute compartment syndromes? So I'll give you some case examples that we go through, and this really illustrates some of the points that I've made before. This is a patient, humeral shaft fracture, that presented with pain sort of out of proportion to what we thought should have been present with the humeral shaft fracture. So we used the MyO1 device, was put into the arm to confirm the presence of an acute compartment syndrome. The ICP was high at 67 millimeters of mercury, and it kept on going up as we watched it. So the curve was that of an ascending pressure device, as I'll show you some of the curves. So acute compartment syndrome was confirmed and a fasciotomy performed. This is a patient where MyO1 helped avoid a fasciotomy. There's one we're all troubled with. We have a patient who presents with a crush injury to the limb, their end organ failure, neurologically impaired. They can't tell us what their clinical situation is such, and the compartments are tight and people are looking at us to do something. We put the MyO1 device in place. Pressures were low, as you can see from the curve, and fasciotomy was avoided. As the delta P was very elevated, not low, as we'll see some of the other ones coming up. It really drops down if you get acute compartment syndrome. This one is very high delta P's and low curve, so very comfortable to wait it out, and the patient did not develop an acute compartment syndrome. That really reduced the chance of getting wound issues and difficulty closing this type of crush injury. This is another one where it really leads to the credibility of the device, where femur fractures we all seem to feel have a very low chance of developing compartment pressures. Here's a femoral fracture. Clinically, the patient didn't present with any problems. We nailed the femur, the difficulty, and pressure started off post-op at 20 millimeters of mercury, remained stable over time, and didn't develop an acute compartment syndrome. And I think it just correlates that what we think happens in the thigh is indeed what happens in the real patient with the MyO1 device in place. Here's another patient with a tibial nail, and this is a little bit different. So acute compartment syndrome was absent, again, post-IM nail, and the patient had a tibial shaft fracture. We took them to the OR, put an IM nail in place, and the device was inserted post-op in the anterior compartment immediately after the IM nail. And this shows you a very high reading of 70 to 80 millimeters of mercury, which I was very concerned about. But again, watching it carefully, you can see it drops off very, very quickly, and the delta P comes up to the normal levels that you'd expect. And there's no evidence of compartment syndrome clinically. The patient's wide awake in the post-PACU, and no evidence of any compartment syndrome. So again, this goes along really with Margaret McQueen wrote about this in the past, with hypertension developing post-IM nail or post-plating of a tibia, and you can end up with high compartment pressures instantly afterwards, but they drop off very quickly. So this correlates with what she described in the past. So again, here's another patient who has bilateral, both bones of the forearm. You can see a curve starts off quite high after the insertion in one of the forearms, and then improved to be about 33 millimeters of mercury, which we thought was quite good at 6 hours. You can see it doesn't continue to drop. So normally you'd expect this to drop, and I'll just back up. You can see here the drop of the curve we normally would like to see post-op would be like this one on the tibia, right? So here you have it in the forearm, it's not dropping off. And indeed, if you look at the curve from 6 hours to 18 hours, it actually goes up a little bit. So we were worried about that. We presented that data to the surgeon, who felt clinically the patient was doing well. But 3 hours later, the patient developed clinical compartment syndrome and had to go back to the OR to get both forearms fasciotomized. So it just shows you that the clinical reading of these MyO1 devices can be ahead of the clinical picture. This is another one that really showed how this device can read it as far as measuring the compartment pressure much sooner than you can clinically. It's a tibial midshaft fracture. The device was inserted pre-op, so planned for fixation the following morning, not a compound injury, not a concern, put in IMCU, and followed along very carefully. And you can see at about the 6-hour mark, you start to get a divergence where the delta P starts to drop and then the curve starts to go up. So there was no clinical signs at this point in time until he got to the OR. As he got there, he developed a little bit of discomfort and a little bit of paresthesias around the first web space, but that was all he showed, and that was at 18 hours post-insertion. You can see here I just enlarged the curve. You can see where delta P starts to drop and the curve starts to go up, and that's be an indication to me now, looking at this, that that patient is going to develop a compartment syndrome, and you could take that patient to the OR anytime that's convenient to them and to you, release that compartment in a very predictable fashion. So I think there's a paradigm shift happening from single point readouts to continuous pressure monitoring. It's happened before in our clinical careers. Intracranial pressure monitoring used to depend on one number. They'd put a needle in and measure it and do that often. Now the trends and curves are what's more important. You know, they look at a curve and decide whether they have to do something as far as a burr hole or craniotomy is concerned. CBP monitoring relies on trends, not absolute numbers. O2 sat monitoring really changed the way patients are monitored and brought down the CMPA cost to anesthesia. And we think that as our full study develops and we get more patients involved, we think it's going to confirm our preliminary data that continuous pressure monitoring will make it safer for our patients and surgeons by supporting our clinical judgment. And in those crush injuries and neurologically impaired patients, may reduce our prophylactic fasciotomy rate in those patients as they are unnecessary, as long as you have objective data that supports your clinical impression. And or it's going to, more importantly, it's going to allow us the opportunity to diagnose an acute compartment syndrome much sooner than being able to perform to date, relying only on the patient's symptoms. This will provide added safety for our patients and our colleagues, of course, as well as value to our hospitals and institutions. So I think in conclusion of this preliminary data, I think it's difficult to diagnose acute compartment syndrome in some clinical situations, but it still remains clinical. And so as surgeons, we desire objective evidence to support our clinical judgment. And right now, the only thing we have really is the white size technique of putting a catheter into the limb and hoping that we can pick up enough pressure to decide what to do and support our clinical judgment. I think as Margaret McQueen showed with continuous pressure monitoring, that this being used as an adjunct to clinical examination can lessen the overall risk by balancing the significant clinical, medical, legal consequences of a missed compartment syndrome and the possible risks of overtreatment. But I think it really can help us make the diagnosis sooner and before the clinical picture gets dire and they have a limit risk. So I think continuous trends in ICP could provide objective reassurance of a lack of compartment syndrome in the neurologically impaired patient, and more importantly, can provide an early warning signal of acute compartment syndrome developing in a patient, even prior to early clinical signs of paresthesia and increased pain. And I believe as this goes on, we'll find that paresthesia and increased pain will be a late finding if you measure continuous compartment pressures going forward. So I really think it's going to change the way we measure these things going forward and help our patients and help our colleagues make the diagnosis in an earlier, more predictable fashion.
Based on your experience, what was the most valuable use of the device?
I think the ones I kind of pointed out, to me, I'm pretty comfortable looking at patients clinically. So you think you can make a pretty good diagnosis. But the two things that were interesting to me was, number one, in the neurologically impaired patient, I really don't have any clinical way of deciding whether that limb needs to have a fasciotomy or not. So if I was worried at all, I would do fasciotomies because I had no other way of measuring it. And the white size technique is possible, but it wasn't always predictable, and it's kind of hard to use on a regular fashion. So I think this is way better that way. The second thing is how early you can see that. And I think that's supported by Margaret McQueen's study in 2021 that says that you can pick these up much quicker with continuous pressure monitoring. So I think this feasibility study shows that you can pick it up much earlier. So that's very exciting, and I think going to be real helpful to all of us going forward.
The next question is a nice follow-up, actually. You showed some case examples of post-op use. So, how does the device complement your clinical assessment of pain in a post-operative setting? Do you find that pain is always reliable?
I think not always. No, I think that with this device, I found that pain and paresthesia are actually a little bit late, finding in patients. So by the time they get that, they really got a rip-roaring compartment syndrome on the go. Whereas I think if you can watch a trend and continuous pressure monitoring and watch the trend either go down, which makes you reassured, or go up, that makes you nervous, I think that really adds to the whole situation. So post-op, you nail a patient and you think everything's going well, and then as they start to go through the post-op recovery room, you see this thing going up and not going down, you start to get a bit worried that this may not be settling down the way it normally does. So it should drop rather precipitously between hour 1 and hour 4. If it doesn't do that, then you start to worry about what's happening with and that indeed, if this starts to go up at that level or even flatten out, so even a flat curve at that point would be a worrisome sign to me. So I think it really helps you worry about the patient that needs you to worry about them and forget about the ones that are getting better. It's more important than the absolute number. That's the key. I think that this is going to take away, as we go forward, I think discussing absolute numbers will be a thing of the past, and discussing trends in the curve will be what's going to be important going forward.
We have another interesting question related to the use of the device. Where do you see the device most used within the hospital as a whole?
Yeah, there's two places I believe it's going to be used. Number one, in emergency department. If you feel that you can wait overnight, which most of us do these days, if you get a patient in that looks otherwise clinically well with a long bone injury, you can do it first case in the morning. And then the trend in orthopedics would be to wait overnight and do it first case in the morning. So I think that's the patient where I would put a device in to make sure that while I'm sleeping that he's doing okay. And then the second, the patient, you get to the OR and you do a IM nail of a tibia or a forearm that's opened up, and you close it up, and you think you can close it. It's kind of snug, but you're feeling that everything looks okay and you don't want to leave the wound open. So you put a device in to protect the patient and protect you from a compartment syndrome developing, giving a closure of the wound. And I say most of our open wounds now, we close about 80% of them or 85% of them the day of. So it's a lot different now than it was when we left them open for 2 or 3 days. So those early closures can come back to bite you if you don't have a good device or good clinical attention to detail after the post-op. So I think those are the type of patients where you want to think about using the device pre-op, before you operate because of the significant trauma, and post-op because you've decided to close the wound and watch the patient clinically.
What are your key takeaways from the first 30 patients of this prospective study?
Well, I think key takeaway, I want to see what the other 70 patients look like. That's the key takeaway, that this is a preliminary study. But no, I think it's really exciting. We thought about this beforehand of what these curves might look like in real life patients. And they're very exciting to look at because it gives you things you can talk about amongst yourself, with your colleagues and with your residents and other partners. What's happening with the patient, what do they look like clinically? And so I think the discussion becomes at a much higher level as opposed to fasciotomy versus no fasciotomy. It's how do they look? Does the clinical picture correlate with your curve? And then you make a decision based on all of the findings. So I think it's a much higher level decision making situation now than what we had prior to this. So that's the key takeaway, is that there's much more information at your fingertips to make a valid decision on your particular patient.